Welcome to Ink and Air from OptimalAnesthesia.com.
Great to be diving in again.
Today, we're taking that deep dive inspired by a conversation we noted on Ink and Air, the one titled Anesthesia Unveiled, Tackling Radial Head Surgery with Precision.
That's right. And we're really zeroing in on the first part, breaking down radial head surgery, an anesthesia perspective.
Yeah, we want to unpack what actually goes into prepping a patient for this kind of operation from the anesthesia viewpoint.
Exactly. Our mission here is to pull out those key considerations, maybe some surprising bits that come up when you have, an anesthesiologist and a surgeon talking shop about radial head surgery.
Trying to give you that clear, insightful look at where these specialties meet.
Precisely.
Okay, so let's set the scene. We've got a 42-year-old woman, radial head fracture from a car accident. Right then, initial moments, what's flashing through the surgeon's mind versus the anesthesiologist's?
It's fascinating, isn't it? It's like two tracks running at once. The surgeon, understandably, is focused right on the injury.
The break itself.
Yeah, the specifics, how bad is it, fix it, replace it. What's the best surgical approach?
Okay.
But the anesthesiologist, we're aware of the surgical plan, obviously, but we're immediately zooming out, thinking about the whole patient.
Because of the car accident.
Exactly.
Yeah.
The trauma. How does that impact her overall? Can she safely handle anesthesia? It's about the bigger picture, the patient context for this specific injury.
So the anesthesiologist becomes a bit of a detective right away. That preoperative assessment, what does that look like?
Absolutely. Detective work is a good way to put it. That mechanism of injury, the car accident, that's a huge clue.
Red flag.
Sort of. It means we have to actively look for other injuries, things that might not be obvious. Did she hit her head? Any neck pain? Back pain?
Stuff that seems separate but isn't for anesthesia.
Precisely. It all feeds into the plan.
Yeah.
Then you need a thorough medication history. What is she taking? Any interactions? Anything affecting her health generally?
And you mentioned before the pregnancy testing question for women of childbearing age is always part of it, right?
No.
Critical.
Oh, absolutely critical. Non-negotiable, really. Some anesthetic drugs, the surgery itself, they can pose risks if someone's pregnant.
So you need to know up front.
Need to know. For the safety of everyone involved, potentially the patient and a pregnancy, it's standard procedure in that initial workup.
Okay, so that initial detective work is done. What about the standard tests? Labs, imaging, that kind of thing before surgery?
Right, so we need a baseline. A comprehensive workup tells us where the patient stands health-wise. Usually involves blood tests.
Like a CBC?
Yep. Complete blood count checking for anemia, infection. Then kidney and liver function tests, make sure those organs are working okay. And a coagulation profile, super important. Tells us how blood clots.
You don't want surprises with bleeding during surgery.
Definitely not. It's a balance,
Yeah.
right? Not clotting too fast, not too slow. And for patients over 40, like this woman, an ECG electrocardiogram is standard too.
Checking the heart's electrical activity.
Just screening for any underlying cardiac issues we need to be aware of.
And imaging. Obviously, the surgeon needs a good look at the elbow.
For sure. Detailed elbow images, x-rays, maybe even a CT scan. That's essential for the surgeon's plan.
But you mentioned the car accident again.
Right. Because of the trauma mechanism, we have to think broader. Is there any chance of chest trauma? If symptoms or the accident details suggest it,
You'd get a chest x-ray.
yeah, got to rule out lung or rib injuries. Can't be too careful.
Okay, makes total sense. So, pictures built, patient assessed, tests done. Now, the big anesthesia decision, general versus regional. Here, general was the choice over a brachial plexus block. Why?
This is a great example of balancing different needs. Sure. A brachial plexus block, numbing just the arm, sounds good for elbow surgery, right?
Yeah.
Maybe less groggy afterwards.
Seems logical.
But there were really important reasons to go with general anesthesia here. The main one. We need to be able to do a good nerve assessment after the surgery.
Because the surgery itself could potentially affect nerves.
Exactly. There's always a small risk. And if the arm is numb from a block, you wouldn't know if there's new numbness or weakness starting. It masks the problem.
Delaying diagnosis. Not good.
Not good at all. You want to catch that stuff early.
Okay, that makes perfect sense. What was the other big factor against the regional block?
The other major concern was compartment syndrome.
Right? That's serious.
Very serious. Swelling inside the muscle compartments cuts off blood flow, damages nerves. And one of the earliest, most reliable signs is pain. Intense pain.
And a nerve block would take that pain away.
Completely. So you'd lose that crucial early warning sign. You might miss the window for urgent treatment, like a fasciotomy to relieve the pressure.
Wow. Okay. So general anesthesia keeps that window open for assessment. Let's move into the OR. Patients under Gisral. What are the key things the anesthesia team is focusing on?
Okay, patient's asleep. Now it's all about meticulous care. Positioning is huge.
So for the surgery?
Usually supine, so lying flat on their back. The injured arm gets carefully placed on a padded bolster, often across their chest.
Oh, I like that.
The goal is a neutral, comfy shoulder position. No extreme stretching, no pressure points that could hurt nerves later on. We're also making sure the airway is totally secure, all the monitors are on and working right, IV lines are solid for giving meds.
Seems basic, but clearly vital to avoid causing new problems.
Absolutely. Now, during the surgery itself, the surgeon often uses a tourniquet, upper arm, creates that bloodless field they need.
And the anesthesiologist manages that.
We play a key role in its safe use, yeah. We make sure it's padded properly, protect the skin, the nerves underneath.
Okay.
We watch the pressure setting, usually 50 to 75 millimeters of mercury above their systolic blood pressure. Often lands around 200 millimole Hg.
But the timing is the really critical part.
Oh, obsessive attention to timing. We log the exact inflation time. We give reminders, usually every hour, tourniquet check, and we carefully document the release time.
Why so strict?
Because prolonged pressure can cause nerve damage, even muscle damage. Sticking to time limits minimizes that risk significantly.
That detail really drives home the constant vigilance needed.
Okay, what about fluoroscopy? The X-ray guidance during surgery?
Yeah.
Any specific anesthesia role there?
Radiation safety is definitely a team sport in the OR. We're actively involved.
Oh.
We push for things like using the pulse mode on the fluoro machine, proper collimation basically, techniques to reduce the overall radiation dose,
Right.
and making sure everyone in the room has their lead apron and thyroid shield on. That's mandatory, non-negotiable.
Protecting the team, too.
Absolutely. Plus, we track the patient's exposure using specific metrics, cumulative air tremor, dose area product, lets us quantify it, and ensure safety.
Good to know. Okay, let's circle back to pain. Since there's no nerve block, how are you controlling pain during the actual operation?
We use what's called a multimodal approach, basically hitting pain from different angles with different meds.
Like what?
IV paracetamol, that's pretty standard, maybe an NSAID, a non-steroidal anti-inflammatory if it's suitable for the patient.
Small, really carefully controlled doses of an opioid, like fentanyl, for the sharp surgical pain.
Anything else?
Yeah, we might add adjuncts. Things like low-dose ketamine or dexmedetomidine. They can help with pain and sometimes reduce the total opioid needed.
And the surgeon contributes too?
Often, yes. Injecting local anesthetic right into the surgical area before closing up, it all adds up.
A real multi-pronged strategy then.
Oh.
So surgery's over. What's the post-op pain plan?
We continue that multimodal idea. Regular doses of paracetamol, probably an NSAI.
The basics.
Right. Then for breakthrough pain, if it gets worse, maybe something like tramadol or if needed morphine, but critically, because there's no block,
You need those nerve checks.
frequent thorough nerve checks,
Yeah.
radial, ulnar, median nerves in that arm. Got to catch any post-op issues early.
And still watching for compartment syndrome.
High alert. We brief the nurses, tell the patient what to watch for. Severe pain that seems way out of proportion, lots of swelling, changes in sensation or finger movement.
Because that needs urgent action.
Immediate surgical evaluation if those signs pop up. Time is critical.
Okay. Beyond the immediate pain and complications, what else is part of the bigger recovery picture?
Well, several things help ensure a smooth recovery overall. If mobility is limited after surgery, we think about DVT prophylaxis preventing blood clots.
Medication or compression devices?
Could be either or both. Then there's wound care, obviously important to prevent infection, and maybe the most crucial thing for long-term function,
Physio.
early physiotherapy. Getting that elbow moving again, regaining strength, absolutely key.
So we hope this deep dive, really drawing from that ink and air discussion on optimalanesthesia.com, has given you some maybe surprising insights into just how meticulous perioperative care is for something like radial head surgery.
And remember, you'll find even more detailed explanations, the evidence-based stuff behind these topics over at optimalanesthesia.com. That content should be rolling out starting June 2025.
It really shows, doesn't it, that anesthesia is so much more complex than just, putting someone out.
Absolutely. It's dynamic. It needs deep knowledge of physiology, pharmacology, potential surgical pitfalls, all focused on patient safety, comfort, and getting the best outcome.
Yeah, this whole exploration sparked by ink and air just highlights that teamwork, that collaboration, and the constant, unwavering attention needed through the whole process.
And think about this. We just talked about the anesthesia choice for a, relatively speaking, common surgery. But that one decision branches out into so many considerations: patient history, surgical needs, potential complications, long-term
It
recovery.
makes you wonder,
It
right?
really does. What other medical decisions that seem simple on the surface actually hold that same kind of depth, that same complexity requiring multiple experts weighing in?
Definitely something interesting to ponder as you keep learning about medicine.